My topic is the ugly part of diabetes, and in particular, speaking about diabetic foot infections. So this is the classic look of a diabetic foot. You notice what we talked about a little bit of where the location of the wound is, mainly at the pressure point. The foot looks deformed, and if you can look even further, you see that there's probably bad circulation in that foot. But that's how usually these patients will present, and I'm going to focus more of a in-hospital approach, what you should be looking for and what you should be doing. So like Dr. Koligan said, this is a very common problem. Amputations are very common, but it's usually the result of a misdiagnosis or a mistreated infection. Infection is defined in our literature as two or more classic findings for inflammation or purulence. And you know all these all too well: redness, warmth, swelling, pain. If you see pus, then that's a no-brainer. Foul smell. Clinically uninfected wounds usually do not require any antibiotics, and that's when that's the challenge. When somebody shows up with a chronic wound, you have to decide, well, is the wound infected or not? Does the patient need antibiotics or not? Here's another look at a diabetic foot ulcer, and you can see it's quite deep, and the margins are sort of elevated, kind of coming off. But you can see there's not a whole lot of redness, and you don't see any purulence, and that's not uncommon even with infected wounds in diabetics. We just had a patient in the ICU come in septic. We couldn't really find a source, and he's a diabetic. Apparently he had some Chinese food the night before, and they were attributing to perhaps a food poisoning problem, and his foot was just a hint of redness, and there wasn't any pain, there wasn't much swelling, but the wound grew MRSA, and as soon as we started the vancomycin, the patient got better. So you have to really be vigilant about these foot infections. Antibiotics should be based on the cultures that are obtained from the wounds. Imaging studies such as plain films, MRI, bone scans can help you when you are trying to figure out if this is just a superficial infection or is there any worrisome scenario for osteomyelitis. If osteomyelitis is suspected, we always recommend deep tissue samples to be obtained, bone preferably. This is for micro studies, and we always push for the surgeons or the podiatrist or the interventional radiologist to help us out and get a deep tissue sample prior to starting any antibiotics. That increases our yield significantly to actually grow an organism and target our therapy better. Remember, these patients usually require a prolonged course of therapy, 6 weeks minimum, and so you want to be as narrow as possible to try and avoid any adverse side effects. Be aware of those factors that increase the risk of diabetic foot infections. These factors, we can name a few. Probe to bone test. If you can touch the bone, then you have osteomyelitis. If the ulceration has been there for more than 30 days, and then you probably are dealing with a deeper infection than what the eye can see. If the patient has had ulcers in the past, or trauma to the foot, peripheral vascular disease, and if they've had a previous amputation, these are all factors that you need to take into account. Other factors that you need to take into account are the loss of protective sensation, the presence of renal insufficiency, and a history of walking barefoot. There are guidelines that were just published last year in infectious diseases by the Infectious Disease Society of America. They are helpful. They make some of those gray areas a little bit clearer, so I would refer the interested reader to the June 2012. So that's the ugly. You see the maggots, you see the erythema, you see the wound looks necrotic, the skin looks stretched out, so there's edema. So who do you hospitalize? This is a very common problem. So if the patient has a severe infection, obviously you have to hospitalize the patient. How do you decide who has a severe infection versus a mild infection versus a minimal superficial infection? Well, that's where your physician skills should kick in. Always pay attention to the patient as a whole, the vital signs, what the glucose is doing lately, etc. But the people that we choose to hospitalize are those that are very ill, the ones that we suspect are very non-compliant, the ones that have a lot of peripheral vascular disease, those that have failed therapy as an outpatient. Again, examine the patient as a whole, look at their feet, but also look at the patient as a whole. If they're tachycardic, febrile, a bit hypotensive, if their mentation is off, and that's usually the first thing that will go, is family will notice that they're acting a little funny. Recognize poor circulation, wound severity, characteristics, recognize the potential of limb threats. There's peripheral vascular disease, and the extent of the infection. If the patients look like they're septic or very ill, then antibiotics are indicated, and this is empiric therapy. Always we rely on our colleagues, the wound care center, and also from the diabetes nurse to wound care, podiatry, IR. So this should be a multidisciplinary approach. I'm not going to be able to cure that patient if I don't have this team with me. So internists, infectious diseases, vascular surgeons, the wound care specialists, ortho, physical therapy, social work, etc., are very important. We all try and work together with one single goal, which is get the patient better and save the limbs, prevent further episodes of infection, decrease hospital admission, reduce morbidity and mortality. Obviously, that's our goal. When to obtain cultures? When the wound looks infected. So we went through the classic signs of inflammation. When that wound is not looking good, it's always a good thing to swab the wound. We don't recommend swabbing the wound superficially, because usually we'll grow just a bunch of organisms that are not necessarily representing what's going on inside the foot. But if you don't have any other information, you can't go wrong by just swabbing it, because that may help me and decide which antibiotic to use if I have no other data to go by. Deep tissue sample is always what we want. Avoid the superficial swabs if you can. But if we have nothing to go by, go for it and just swab it. So if you were to swab this wound, it'll probably grow every single organism under the sun. So when I usually see something like this, I don't swab the wound superficially. I recommend, well, this foot probably has to go. But if it was a smaller wound that we can save the foot, I would recommend a deep tissue sample for antimicrobial therapy selection. Antibiotics are always indicated in patients with infected wounds. It's a combined approach with antibiotics and wound debridement. Don't withhold antibiotics in those patients that look sick. If they're septic, then go ahead and culture what you can and then start the patient antibiotic. We can always de-escalate the antimicrobial therapy. Some possible choices, and these are for outpatient choices. Augmentin, which is a very broad antimicrobial, levofloxacin plus flagyl, or levofloxacin plus clindamycin. And once you've obtained some type of culture, you can always refer back to that culture and change the antimicrobial around according to what grows. Keep in mind toxicities, acute kidney injuries, rash. The longer you keep somebody on an antibiotic, the more likely they're going to develop a side effect. Treat for about 1 to 2 weeks in mild cases, 2 to 3 weeks or longer in wound infections that are a little bit more severe. IV antibiotics are recommended for those patients with severe infection. The organisms that are usually involved are strep and staph. These are mainly in the acute setting, but chronic wound infections could be any organism: strep, staph, gram-negatives, anaerobes. If the patients are sick, broad coverage is what's indicated, even for Pseudomonas. Sozin, Cipro or levofloxacin, ceftazidime, cefepime. These are in the hospitalized patient that look very ill. You want to cover Pseudomonas empirically after you obtain some type of swab and wound culture. Staph, need to keep in mind Staphylococcus aureus, MRSA in particular. Vancomycin, daptomycin, and linezolid are good choices. And always the anaerobes. Unicin, Sozin, metronidazole, or clindamycin are our choices. Culture first what you can, blood and wounds, and then start the patient on an antimicrobial. If the patient has got a cellulitic foot, but there's a mild infection, they're not looking septic, the infection doesn't look like it's a limb-threatening infection, I like the approach of using Unicin, culturing what you can, and then wait and make your selection according to what grows. That's usually my preference. Think about osteomyelitis. The wound may be deeper than what you can see. This is a classic diabetic foot ulcer. You can see it's pretty much in the same location, and it's got that thick skin around the ulcer. It's been there for a long time. It doesn't particularly look infected if you see it like that. Osteomyelitis, think about osteo in a chronic wound that's non-healing. You can assess for evidence of osteo by plain films. I would start with that. An MRI is also maybe helpful as well, or a bone scan. If the patient looks stable, you can wait until you get a good deep tissue sample and send it for culture and gram stain. This is the MDA is the multidisciplinary approach. That's when you call in your podiatrist, wound care center. If the patient looks like it has peripheral vascular disease and may benefit from a vascular procedure, get those guys on board as well. Do not hold off any antibiotics on the patient that looks ill. I think that's a given. Or the limb looks like it's rotten. Don't hold off on antimicrobials on those kinds of patients. Remember to keep your toes dry and look at your feet every day.